Hello, welcome back to Fertility Fact or Fiction. I am your host, Dr. Rahi Victory, a reproductive endocrinology and fertility specialist. And I have to say, it kind of feels like it's been forever because we missed you guys last week for Valentine's Day. But it is very good to be back, excited to be with you. This is kind of the last show we're going to be doing in this format. Moving forwards, we're going to be talking more with other interviewers. We are going to be reviewing more studies again, and we are going to be looking at cases because we're not going to be offering direct medical advice anymore. So huge disclaimer just for everyone who is watching. Everything we say on the show is opinion only. If you need medical advice, you have to seek a consultation with a qualified physician, be that myself or any other RE. Make sure that you understand that these shows are opinions only, and they're my opinions in this case. So, or I guess occasionally Tarek's opinions.
Always
too.
my opinion. I think that's the safest route.
Occasionally Tarek's opinion too. So I am here with my trusty friend Tarek Ibrahim from Ibrahim Strategies Group. And he is our wonderful social media guy who plans all of this stuff. So yeah, this will be the last time we kind of directly answer live questions. Moving forward, we are happy to look at cases. We are happy to look at specific topics. If you want us to talk about endo, PCOS, infertility, certain circumstances, we can build that out without kind of directly answering people online. Because we want to make sure that we are conscientious of not stepping on anyone's toes and not creating a problem for anybody. We don't want anyone to think that we're giving them medical advice without thoroughly knowing your history. And I know I say that every time, but for medical legal reasons, we want to keep it squeaky clean. So thank you for joining us. Hope you guys had a great Family Day weekend. For those of you who have families, hope that it was a wonderful weekend filled with lots of love and laughter, as mine was. And for those of you that are building your families or trying to start a fuller family, we are here to help you out in every way that we can. So hopefully we'll get through some of that stuff. I very much wanted to present a new article tonight. There is a good article finally about the use of progesterone for treating women who have first trimester bleeding and whether or not it would reduce miscarriages. So I'll have that ready probably for next week. And next week we will have a egg donor and surrogate on to talk to them about their journeys. So if any of you know people that are considering being an egg donor or a surrogate, or anybody has questions about being an egg donor or surrogate, you can ask them because they're not medical personnel. They can answer all your questions. So they will be on to, go through that. Once you get views, the comment section is going to be a SHIT show. Yes, very true, probably. Super happy to have you guys all here. If you have questions, please don't make them personal about your case. We cannot address things like I am 32 and have so-and-so. So if you have generalized questions about low AMH or questions about what an embryo is and just general educational stuff, that we can do, but we cannot offer you medical advice directly without having consultation. You have to become a patient for that. And we may move into a model for that where we will do like teaching sessions for people and allow that kind of thing, but it would literally be a segment where you would have to become a patient, and whether you're signing up through your family doc or paying for it privately or whatever, that's fine. But and it's not a money thing. We just need to make sure that you are a patient before I can give you medical advice. So we'll work those details out when we come in. Hi from Alberta. That's pretty cool. I know. I was just out west. Huge shout out to my wonderful children out west, and to my incredible son who is more east. So we went out west to Vancouver to visit our kids, where we found out that my middle son is the sponsor of the cordyceps infection from The Last of Us for the crap I found in his fridge. But otherwise, we had a good time and enjoyed ourselves, and had a good time. Yeah, it was great out there. Hello from Kingston. Oh my gosh. SMBC Canada is from Kingston. I went to medical school in Kingston, so that's super cool. Hello back. Okay, so I think tonight we're just going to kind of do it the old-fashioned way, and then moving forward it'll be different. So this will be the last time we directly answer questions. Again, huge disclaimer, and hopefully you can see it on your screen. For those of you on TikTok, you cannot, but these are just opinions. I'm not offering medical advice. For medical advice, you must seek out the assistance of your physician and someone that you've had a thorough consultation with.
So, thinking of the best way to paraphrase it,
Uh-huh.
right? But I was thinking,
Yeah.
can high level insulia impact the transfer?
High level what?
Insulina.
Insulin.
Oh yes, probably spelled wrong. Yeah, insulin. Yeah.
Yeah, so insulin and fertility is a good topic to discuss, so we can talk about that for a bit. So there are many people who have elevated insulin levels, and when they have elevated insulin levels, that insulin elevation is usually due to insulin resistance. So if you are resistant to your body's insulin, your insulin levels go up. And what happens at that point is your body is trying to find sugar and drive the sugar into your cells. And at the same time, what's very much happening is that you're storing everything that you take in. So all of the calories that you're consuming try to get stored because your body actually thinks you're starving. And when your body thinks that you are starving, it tends to want to store everything in case you continue to starve. So elevated insulin levels are associated with high sugar levels. When the sugar levels are elevated, your insulin levels also go up again to drive the sugar in. And that in general can lead to significant inflammatory states. Those inflammatory states are generally considered to be suboptimal for people who are struggling with anything, including fertility. So anytime you have an elevated level of inflammation in your body, that's clearly not a great position to be in. And certainly from a fertility perspective, there are whole journals dedicated to the idea of your immune system and the inflammatory milieu in your body in relation to where you are at and in your success rates with fertility. So it is really, really important to try and avoid high insulin levels. So what's the most common association with a high insulin level? Obviously obesity. The more adipose tissue that a person has, the higher their insulin resistance is going to be, and therefore the more that they are going to have higher levels of insulin. And so it is critical to bring weight down. There are many, many, many studies demonstrating detrimental impact of obesity for men and for women on the success rates of your fertility. So if you're looking at sperm, we definitely see lower numbers of sperm, lower motility for sperm, lower vitality for sperm, higher numbers of abnormal sperm when we have men with obesity. In fact, in men, when you're obese, your estrogen levels tend to go up, which completely counteracts a lot of the stuff that we want in our bodies because we're more testosterone dependent. Women are definitely more estrogen, progesterone dependent. So when we get high levels of estrogen, definitely not a good thing. In women, conversely, when you have very high levels of adipose tissue, you actually end up producing a lot more testosterone, and that's not great in a woman because you're supposed to be estrogen and progesterone dependent. So there are some very negative impacts from high levels of insulin. The most common place we see it in the fertility realm is definitely when you have something called polycystic ovarian syndrome. So for those of you that don't know what PCOS is, it's a condition where the ovaries are not functioning entirely properly. They're not responding the way they should be to the signal the brain is sending to grow an egg and mature an egg and release an egg. And as a result of that, the eggs end up starting to grow, but they never fully complete the process. And what ends up happening in that scenario is you get lots of little eggs. So when you look at it on an ultrasound, it looks like lots of little cysts. And that's where they came up with the name polycystic ovarian syndrome. The thing that biochemically happens in those women is that they get very high levels of estrogen, very high levels of androgen, which are male hormones. And then they get insulin resistance, elevated levels of insulin-like growth factor, and all of those contribute to, again, very significant infertility problems, irregular periods, obesity, high blood pressure, metabolic syndrome, diabetes or pre-diabetes, hair growth, acne, So there's a lot of different issues that go with it. And so these are all things we desperately want to avoid. So how do you avoid getting those high insulin levels? There's medical therapy. So if you have irregular periods, your PCOS, we always talk about the various medications that you can use. And there are medical therapies you can use. Examples would be things like letrozole and or metformin. Again, talk to your physician before you try anything. There are supplements that people believe are useful, things like NAC, inositol, coenzyme Q10, resveratrol. All of those have been shown to have some impact on insulin resistance. And then there are lifestyle choices. So if you are carrying extra adipose tissue, healthy eating, which is, for example, 6 meals a day, intermittent fasting may be very beneficial. And then exercise, and exercise is exercise where you are building muscle, because the more muscle mass you have, the more calories it takes to maintain. And so more of the calories in your body and that you take in get used just to maintain your muscle, which means less for storage. And what you're trying to do is break up that cycle of storage. So yes, very much so, insulin can negatively impact your embryo transfer protocol. It is important for everybody to be very cautious about their insulin levels, their sugar intake, the inflammatory milieu of their body when they're doing any kind of fertility therapy.
Hello from Vegas.
Cool. Actually, somebody reached out to us today earlier from Vegas too.
Hello from Puerto Rico.
Oh, wow. Cool.
We got a lot of people saying hello from all over the place.
That's great.
It's amazing. They love you, Dr. V.
Well, that's great. Hi, Dr. V. Oh, Kristen. Hey, Chris.
Ready?
Yeah.
Question here, they're wondering if a endometrioma should be removed.
Okay, so we can talk a lot about endometriosis. That's a good topic. So endometriomas are cysts of endometriosis that are present on an ovary. So let's start with what is endometriosis. Endometriosis is when the cells that make up the lining of your uterus are found outside the lining of your uterus. So it can literally be anywhere. Most commonly, it's around your ovaries, your tubes, your pelvic wall, maybe on the surface of your uterus, your bladder. It can go into more distant locations like your bowel. I wrote a paper on umbilical endometriosis. There's cesarean scar endo. And then there are people that get it on their diaphragm. You can find it in the heart and the brain. There are some weird locations to find endometriosis. So it can be anywhere, but it's mainly focused in your pelvis. When it lands there, it can create an enormous amount of inflammation, and your body reacts by trying to quell that inflammation. And that reaction can cause scarring, damage, or an elevated immune milieu again, which is not helpful for people that are trying to get pregnant. So you can have mechanical damage from endo, where it's caused scarring and the tube's not working or the ovary's stuck. You can have biochemical interactions where the immune system is overactive. And there are some direct impacts on egg quality and implantation and so on as well. And there's loads of study on this stuff. So when it goes on and then into the ovary, it can create a cyst with quite a thick wall typically of this endometriosis. And they do a lot of damage to the ovary. So from the inside of the ovary, the cyst is growing. So think of it as like an orange inside of an orange peel, and it's putting a lot of pressure on the peel, and that's where the eggs are. And if you start cutting off the blood supply by putting all that pressure against it, you're going to obviously decrease the supply of nutrients to the eggs, and that's obviously harmful to the eggs, which is why in women that have endometriomas, you see fewer and fewer eggs, regardless of whether the endometrioma is removed or not. So where's the big dilemma? You got a cyst, take it out, why not, right? And then you go about your business. Well, the problem is, depending on how the cyst is removed and which study you believe, there are lots of studies that demonstrate that your antral follicle count, your ovarian reserve, your AMH, your FSH, all are adversely impacted, negatively impacted, if you remove an endometrioma. So the problem with this is that for people that have these endometriomas, you can do a lot of damage to the ovary. I've seen many online videos where people remove the endometrioma and they are burning the ovary everywhere where it's bleeding. Well, you just burned a whole lot of eggs. That's clearly not a good idea for anybody. because you're damaging all of the eggs. So the surgery itself has to be conducted meticulously. And then there's the question of, should it be done before, should it be done after, or should it be done at all? So for the people that believe it should be done before, the rationale would be if you can't access eggs in order to do the egg retrieval. So it's mainly done for patients doing IVF. And if you have we're not hooked up for our thing, and it wouldn't work on TikTok anyways.
Well,
But
you could join if you want it, and we could just.
I don't know if I have it. If I have it ready, yeah, I don't know if it's charged. Let me see. I doubt it. It's been a week or two that it's been sitting here. No charge. Okay, so if you have your cyst here, and your eggs are down here at the bottom underneath the cyst, and your needle is coming in this direction, you obviously cannot get there without going through the cyst, and you do not want to puncture an endometrioma. It causes enormous pain. It's a very significant infection risk. There are lots of issues with puncturing endometriomas. So surgically, surgeons always avoid puncturing endometriomas if at all possible. Now, during surgery, it's not the be-all and end-all because we can wipe it clean, but at an egg retrieval, you can't. So we try desperately to avoid that. So if your eggs are all developing below the endometrioma or in a location you can't access the eggs, you got to be really careful about doing the surgery because you could, or doing the egg retrieval, because you can't get to them without going through the endometrioma. So in those cases, you definitely want to remove the cyst first because you're not going to have access to the eggs. However, remember, you are weakening the ovary in almost every study demonstrated. So in those situations, you have to be extremely cautious because you're going to get less eggs out. So yes, you will get easier access to the eggs that are there, but whereas before you may have been able to produce 5 or 6, maybe you're only going to make 3 or 4 now. So you might have fewer eggs develop. And that effect can last for up to a year in most of the studies that have looked at it. For the people that say you should leave it, it's for exactly all those reasons. They're saying you're going to damage the ovary, you're going to weaken the ovary. If you can get around it, you should leave the endometrioma alone. And then there are other people that believe that leaving the endometrioma completely is, not the end of the world, and that you can just leave it and not worry about it. So the problem with all of these different opinions is it all depends on your case, right? So if it's really large, you can't get at the eggs, then it's going to need to be removed. If it's really small and it's not impacting anything significantly, you can probably leave it. If you are dealing with a case where you're going on to do IVF, the inflammation caused by the cyst can actually cause a problem and interfere with the ability of an embryo to implant. So then you have to decide, well, what am I doing? Am I removing the cyst? Am I going to, try and reduce the inflammation? Should we just suppress the patient because there are suppression options available as well? So every case needs to be individualized, and you need to discuss that with your doctor to figure out what's right for you. Carly, I see that you said your specialist told you had to get rid of it. You usually, in our practice, we do try and get rid of the endometriomas because I think the inflammation is significant enough that it reduces chances. But again, every case is unique and you have to look at that. I do have an easy TikTok question that I can answer without getting ourselves in trouble. Do you recommend women over 40 to deliver before week 40 via induction if necessary? We have a great YouTube video on this. We review all of the science behind it. It's part of something called the ARRIVE trial. I cannot advise you specifically, but I will tell you that the ARRIVE trial itself very clearly demonstrated that there are significant benefits for mom and baby, including a reduction in the rate of cesarean section if you were induced at 39 weeks and not waiting till after 40. And it wasn't based on your age. It was actually everybody. So have a look at that video. It's on our YouTube video. It's called Inducing Labor. And it's, I think, number 3 or 4 in our most viewed videos. So check that out. Make sure you hit that like and subscribe button. And if you have comments, comment. But we went through all the data, including the first half of the study, the second half, and several other studies which weren't part of the ARRIVE trial, which also supported the same idea. So check out our YouTube video on that, and that'll help you out a lot.
Is it possible to do FETs in back-to-back months if you're on intralipids, corticosteroids,
Corticosteroids. Yeah.
aspirin, and heparin?
Yeah, so all the immune things that various people use don't necessarily have a time constraint on them. Some of them do, some of them don't. So it depends on what you're on. But as a general rule, without giving any specific advice to anybody, there is no biological reason why you can't go back to back and doing embryo transfers. So there's no biology that prevents anybody from doing a back-to-back transfer. There's also no detriment in waiting. So to be honest with you, we do whatever stresses our patients the least because that makes the most sense.
Hi, Dr. Victory and T. So technically this question could be for me.
It could be for you, yeah.
Right.
Well, if you answer it.
So let's see if I know it. Thank you so much for all your videos. Well, you're welcome.
No. See, that was all T.
There you go. I had a successful FET after several failures when I urged my doctor to go with a lower dose of estrogen
Yeah.
and also some melatonin.
That's you and me, baby.
See that?
Wicked. Good job. Congratulations. Thumbs up from everybody. Yay. Lots of hearts. I don't know.
Lots of hearts.
Lots of hearts.
Yeah, lots of hearts. I'm about to start my first FET cycle.
Okay.
Okay. Do you have any advice on intensity of exercise leading up to and after FET? Can I still run, and do I need to make sure I don't lose any weight? So I can even answer some of this.
You want to try answering some of this?
I can answer some
Yeah,
of this.
I don't know if you're going to get in more trouble or I am.
In my humble opinion,
Yeah.
as a non-medical professional,
Uh-huh.
as long as you are not doing super intense stuff,
Right.
right?
Right.
You're not doing, what do you call it? Spinning, like extreme spinning classes.
Spin. Yeah, spin class.
And
Yeah.
you're not hanging from a chandelier. Things are usually okay.
Swinging from the ship.
Yeah, that's the general rule.
Okay, yeah. So there are studies looking at this, and the answer is super intense exercise in general. And I'm just talking about studies. I'm not offering you medical advice. The super intense exercise has never been shown to be detrimental, but it's kind of frowned upon because if you look at the biology of what's happening when you are exercising, then Carly's got some lovely choice things for us on TikTok. Take a look at what she just said there. Can you see that?
Yeah.
So in general, you're taking blood flow away from the uterus and sending it to the muscles. So that's probably not ideal. And so we don't want super intense stuff, but low, moderate exercise is normal. So that's perfectly fine.
And walking isn't exercise.
And walking is not exercise. That's right. Carly is going to get us
she's
in trouble.
stretching it. She's
Carly,
stretching
I'm not even going to repeat what you wrote there. Everyone can read it on TikTok. That's too funny.
Hola, Dr.
Hola.
VNT.
Hola.
So again, this question, technically,
Both of us again?
There
Yeah,
you go.
that's not going to go anywhere, man.
no problem here. When doing IVF with you from another country,
Yeah.
see, this is a very important question.
Sure.
Right?
Sure.
Do you need the doctor monitoring the cycle to be a fertility doctor, or could it be a regular gynecologist?
No, as long as...
Gracias. From Puerto Rico.
Oh, excellent. No, as long as they know what they're doing in terms of how to measure and we can teach them, it's not a problem. Anybody can monitor for us from anywhere. So we've actually had Puerto Rican patients before, so we're happy to take you. Not a problem at all.
Hi, Dr. VNT.
That's us.
I just delivered and had 2 normal labs before delivery. 2 hours later, I had HELLP syndrome.
Oh,
Can you talk about why HELLP syndrome can be common in IVF pregnancies? There you go.
so we don't know why HELLP syndrome can be more common in IVF pregnancies. Undoubtedly, some of the conditions that lead to people needing IVF may impact the quality of their blood vessels, and it is essentially a vascular disease, so that may have a role. The other issue is that the traditional protocol for IVF embryo transfers has involved a lot of estrogen, and that estrogen milieu is believed to increase the chances of developing preeclampsia, because preeclampsia comes from an imbalance between two chemicals called prostacyclin and thromboxane. And the estrogen probably throws that off when the placenta is attaching and forming. So in that regard, it does place the pregnancies at a higher risk, which is a big reason that the frozen embryo transfers have a much lower rate of preeclampsia than the fresh transfers do. Because in a fresh transfer, your estrogen levels are really high, whereas in a frozen embryo transfer, if they're not pounding you full of progesterone, you're going to be better. Carly asked earlier, how long does it take for NIPT results? So NIPT is the non-invasive prenatal test. That's a test where if a patient is pregnant, they can then go ahead and test for the baby's DNA in the mother's circulation. And if you have an abnormality, they'll be able to detect it. Now, it doesn't pick up all abnormalities, but the big ones like trisomy 21, which is Down syndrome, 13, 18, monosomy X, things like that, it can detect. So it usually takes about 2 weeks to get the results. So hopefully that's helpful. Yeah.
Tetrazoospermia.
Cryptozoospermia. Okay. Yep.
They wrote tetra, but I'm sure.
Oh, okay. Yeah.
Is the result...
It's teratozoospermia, yeah.
Teratozoospermia,
yeah.
That's right. Is the result from my sperm analysis. In my case, morphology is very, I guess, bad. They're all but I'm sure it's very bad. Everything else in the norm. How to counteract bad morphology from varicocele? Surgery is not an option.
So again, I cannot give you personal specific advice, but I will tell you basically that we have a video on this on YouTube about how to improve sperm quality. It's our second highest watched video now. So check that out on our YouTube channel. It's just Dr. Victory in the men's section. But in general, ways to improve sperm quality. So ejaculatory frequency is critical. So we recommend every day or every 2 days. There are many studies that have demonstrated that using vitamins can improve the quality of sperm, although there are also studies that show that it does not. So take that with a grain of salt. You want to keep away from everything bad. So no smoking, no drinking, no drug use. All three of those have innumerable studies clearly demonstrating very significantly negative impacts on the sperm quality, on the sperm DNA fragmentation, and so on. And then especially where a varicocele is concerned, cooling the testicles is likely very helpful. I don't know why surgery is not an option. Surgery should be your first thing to at least consider. So you should be discussing that with the urologist, but I definitely think you should be considering that. That's an important thing to look at because it can significantly alter the sperm performance as well. So I would definitely want to know more about you. So reach out to us if you don't have access to a urologist, get a consult and we'll talk to you about your options. But our YouTube video really talks a lot about how to improve sperm. So that's a perfectly fine thing to look at.
Question here about working the night shift after an embryo transfer.
If your body is used to it, the studies show that it's probably fine. Although shift workers, there are studies that demonstrate that they have a lower success rate than non-shift workers. So if you're flip-flopping between night and day, you are better off to not flip-flop and try and stick with one shift for at least a little while.
I never knew that.
Can I discuss high urate levels in a woman who doesn't drink alcohol and eats red meat limited? So uric acid processing varies from person to person and it has enzymatic components to it. So you would need to probably see a nephrologist or a urologist who can take a look at how your kidney is processing it. There are certain other foods that can increase it. So for people like myself and my dear friend Tarek here who get kidney stones, we desperately need to avoid urates. So it's not just meat. There's lots of different places it can come from, and it's easy to look up online. So I just look up online, foods that increase uric acid levels or urate levels, and go through that. The other thing is, do you have gout? So people with gout have very high uric acid levels, so that's something to look at as well.
Do you recommend IVF with a chocolate cyst 3x3x2 on the back of the ovary?
So these are the questions that I can't answer without having a consult, because I would need to know all the details about you. I can tell you that endometriosis in and of itself is not an indication for everybody to run off and do IVF, but it often can be very helpful, and it does allow us a lot of control over your cycle. So that's something that we would definitely want to talk to you about and go over the details of, and everybody is different, so you can't give one answer to everyone. So in many instances for us, we will look at where your endometrioma is, how big it is, how many you have, what does the rest of your pelvis look like, and then discuss when and where. So frequently for us, it would be your IVF stim, then freeze all the embryos, then we would do surgery to get rid of the endo because it'll be worse after your IVF, and then we do suppression therapy, and then we do your embryo transfer. So to me, that makes the most biological sense. Can I explain the difference between trilaminar and hyperlining? I'm not sure what you mean by hyper. So trilaminar means you can see the bottom layer where the lining of the endometrium abuts the muscle of the uterus, and then the interface between the top and the bottom layer, and then the top layer where the upper lining of the uterus is meeting the muscular wall of the uterus. So it's the basalis, the interface, and the basalis, if you're looking for the technical terms. That's a trilaminar pattern. That's really what we're looking for in order to be prepared for an embryo to implant, because that's what happens in a normal cycle when you reach mid-cycle. From the standpoint of a hyperlining, I don't know if you mean hyperplasia. So endometrial hyperplasia is an overgrowth of the lining of the uterus to the point where it has become abnormal. So there is simple hyperplasia, which just means the glands are overgrowing. There is complex hyperplasia where it's an appearance description and involves pathological findings. But then there's simple and complex atypical hyperplasia where the cells have actually become precancerous. And in the presence of complex atypical hyperplasia, there's actually a 25% chance of underlying cancer. So that's something that needs a biopsy and very close and careful examination. And it happens to fertility patients. PCO women are at very high risk of that. So that's something that every physician needs to take very, very seriously when they're evaluating patients. Years ago, I had a patient who I saw from another community, which actually we're going to be opening a clinic in very shortly. And that patient had gone to see a physician in her home community who had said, you have endometrial hyperplasia, and then had said, go find a gynecologist. So that's just like not a good idea, right? If you have endometrial hyperplasia, it's serious. It needs to be dealt with very seriously. So I actually brought her all the way out here from about 3 hours away. Took care of everything, figured it all out, and then went ahead from there. I can ask one more. Do you have one? You got loads, eh? Yeah, go ahead.
567 billion. Can HPV affect fertility?
Not that anyone has been able to demonstrate in any research studies that I am aware of.
There you go, easy enough. Is an AMH of 6.5 at 31 years of age a concern regarding fertility?
Does it have units?
6.5.
I don't know. I got to know if it's picomoles or nanograms per mil. If you go online, there are bucket loads of AMH graphs. Tarek, you could probably pull one up, an AMH graph, and just post it for people. I can't show you on TikTok, but If you go online and you pull up Amh graph, you'll find graphs of AMH and you can plot it to your age and see if you fall in or outside of the averages. I can tell you if you're in your low 30s and you're 6.5 picomoles, that would be very concerning. If you are 6.5 nanograms, you have super strong ovaries, so that would not be concerning. I'm going to assume it's nanograms, but not sure. An acupuncturist recommended adding fish oil to my supplement routine. Is this a good idea? So fish oils are very good for fetal neurological development. I cannot recommend to anybody they take any medication, supplements, anything, but there is data to support the idea that fish oils are good for fetal neurological development. There is no direct data demonstrating it benefits fertility patients, but it is good for fetal development. So there are studies to support that. So that's something you can pick up on a 3-second search online, no problem.
Add back therapy, is that recommended or detrimental when doing Lupron and letrozole for an endo protocol?
So add back therapy, for those of you that don't know what that is when you're taking a GnRH agonist or antagonist, which suppresses your body's natural ability to make your estrogen levels go down. Like it suppresses your body's ability to produce estrogen. So you want the estrogen levels to go down. And so add back therapy is the idea that if you give the patient back either estrogen or progesterone, it will mitigate the symptoms of having your body robbed of most of its estrogen, which is essentially menopause: hot flashes, night sweats, mood swings, vaginal dryness, sleep disturbance, decreased sex drive. So is it okay to use? Again, I cannot advise people medically. We're trying to avoid doing that anymore. So I can point to studies and so on. But what I can tell you is the idea behind suppression with Lupron and letrozole is to reduce the estrogen in order to suppress endometriosis or fibroids. And the idea of giving add back will bring back some estrogen or progesterone, both of which scientifically can stimulate endo. So I guess I would be asking whether or not that makes sense, because medically you're counteracting what you're trying to do by taking the Lupron and the letrozole in the first place. So talk to your physician and discuss that with them. But the biology behind it, which I'm happy to discuss, is the idea that you are trying to avoid stimulation of estrogen and progesterone to the endometriosis and or fibroids. And by giving add back, you're actually giving back the estrogen and progesterone. So I guess my question would be, why are you taking the suppression if you're going to counteract the suppression?
Which is better, freezing day 3 or day 5? Not planning on PGT testing.
Yeah, it depends on your embryos and what you've done before. The majority of centers worldwide now have moved towards doing day 5 embryos. Very, very few people or places do day 3 anymore for a variety of reasons, some of which are access to PGT, which you mentioned. But it's not for everybody, and sometimes some people do better with a day 3. So again, that's something you have to talk to your doctor about. I would need to know way more about your history. I cannot advise you on something like that. But most places have moved to day 5. That's all I can tell you. I've got one. Hang on. These are floating by before I can even answer them. Count was 8 million for IUI. Is this low? What's considered low? So we have this on our YouTube channel. There are studies demonstrating that somewhere between 9 to 14 million after the wash is what's going to give you a good success rate on IUI. So we have that on our YouTube channel. It's from studies that we've reviewed. One study said 9 million. The other one said 14 million. And it's in the men's section. Can your total motile count, your TMC, predict your IUI outcome? So check that out. And who's a good candidate for IUI versus in vitro? Well, people that have reasonable sperm and open tubes are reasonable candidates for IUI. People who have very low sperm counts, blocked tubes, severe endometriosis, frozen pelvis, those kinds of things, need to discuss their cases with their doctor to decide what's right for them, because there are benefits and risks to each approach. So you have to talk to your doctor and see what they say. This is getting harder with me having to
But you're doing a good job.
dance around.
I feel like you're doing a good job.
Yeah.
I feel like
I
I'm
gotta be
still
careful.
learning. So
Yeah.
I think that's the main accomplishment. I'm still getting my unofficial official doctorate.
Your unofficial, official medical degree. I
Yeah,
love
exactly.
it. Yeah.
High rocking team.
Rockin' team. Love it.
So this isn't even referred to you. This is a
This is
team
just
effort.
us. Yeah.
Yeah,
Team.
this is us. Yeah.
Yeah. All right.
What do you think of 600 units per Percovaris for endo protocol, 5th round? I'd like to say that I don't even know what
Percovaris is?
Percovaris is.
It's a combination of Gonal-F and Luveris in the same shot
Oh, I see.
in a 2-to-1 ratio.
I see. It's a lot of hormones.
Yeah, it's a lot of hormones. How do I answer this one? There are studies looking at low dose versus high dose gonadotropins. We actually reviewed one a couple of months ago on the show. And there are many. In fact, I'm hoping one of these days to work on a YouTube video for you guys on high dose versus medium and low dose and so on. So what I can tell you is that in head-to-head trials of medium dose to high dose medication protocols, no one has ever been able to show a benefit to the high dose. So there are many studies that have shown that taking 450 or 600 versus 300 has absolutely no difference in outcome. There is a very, very recent study in fertility and sterility, which is a review by Richard Paulson and several others, which shows, according to them, and I have not read the whole thing yet, that there is no detriment to taking high-dose meds. But there's definitely no advantage, because that's been looked at 100 times. So if you are taking a high-dose approach, I would discuss it with your doctor. And I guess my question I would ask, because I'm not going to give anybody direct medical advice here, but my question that I would ask is, why am I taking such a high dose? And if they have a logical reason and it makes sense to you, then by all means, that's great. But if they don't have a logical reason, I guess the question would be, then why am I doing it, right? So there is definitely strong randomized controlled trial data to show that there is no benefit to super high doses. The other question, I guess, would then be, is 600 of Percovaris a high dose? It's an extremely high dose. So I would be asking what the utility of doing that is.
IVF successful percentage rate for women 40 years old.
Incredibly dependent on your ovarian reserve, your general health, the quality of the sperm, the lab you're working with, the doctor that you're working with, so on and so forth. So not something that easily be answered. If you look at national statistics, which are readily available to everybody, you can look at the SART data from the US, or you can look at the Carter data from Canada. Off the top of my head, in Canada, I think it was 8%, 40 and above, or 11% in that range. And in the US, it's roughly the same. It's a little bit higher. What do we see clinically ourselves? We definitely see higher success rates, but I mean, I'm super cautious and very careful and very individual for our patients. So we're seeing better results than that, but you do have to go into it cautious. And if you're looking for standardized data that's readily available, that's nationally averaged, those are the numbers. It's not very high, for sure.
How does Urea Plasma affect implantation?
That's a good general question.
That's a
So
great general
yeah, so Urea plasma is a bacteria, and in animal studies, it has been demonstrated to impact implantation and to increase the risk of miscarriage. In human studies, they've actually never been able to prove that it increases miscarriage risks, although there are studies that have gone yes and studies that have gone no, so we're still not clear on that. But essentially, more and more what the studies show is that the vaginal and uterine microbiome, which is the makeup of different bacteria that are in there, are very critical to the success of implantation and the pregnancy. And if you have a poor microbiome, there are many, many studies that have demonstrated that the outcomes are not as good as people that have a good microbiome. So optimizing your microbiome does appear to have a very important beneficial impact on success rates. Is urea plasma part of a good microbiome? No, definitely not. So the reduction or elimination of the abnormal components of your microbiome are likely going to yield positive benefits for you. Are there studies to demonstrate that? Actually, there are not. There are only association studies which show that if you have a weak microbiome or a dysbiotic microbiome, that your chances are lower. But there are no studies yet that show that if you improve it, it actually improves the outcome. There are, however, studies that have shown that if you improve chronic or acute endometritis, you will improve the success rates. And we consider endometritis inflammation of the lining, and it is based on the presence of those bacteria. So it's kind of correlation links. It's not a direct one-to-one thing. I'm hoping with myself and Fertilisys, we can probably have an answer for that in the future. So we're looking at doing that kind of research. How does one improve their uterine microbiome? So first step is testing to see what you have, and then consultation with the physician to see what they think they should do to treat it. And then treatment, which typically will be targeted therapy against whatever abnormal bacteria there are, and then improving it with putting in the correct bacteria, which is basically probiotics.
If someone retrieved 40 eggs, can they be considered low-grade quality eggs?
So the question is, as a general rule, can people producing high numbers of eggs have bad quality eggs? And the answer is eggs and quality have some association together, but not necessarily. So we've had patients in the past where I've made many, many eggs for them, and they were all immature, or they weren't good quality, or we didn't end up with good embryos till we actually made less. And then we have egg donors who can produce 30, 40 eggs, and they're all fantastic and turn into great embryos. So there is no one-to-one biological relationship between your egg count and your egg quality. Best example of that is the fact that we do natural cycle IVF frequently. And in natural cycle IVF, you can still end up with patients who get pregnant off of just one egg. And they're doing it frequently because they're only capable of making 1 or 2 eggs. So even with a very low egg yield, they're getting a positive outcome. So your egg count is not necessarily directly linked to your egg quality. As a general rule, the stronger your ovaries are, up to a point, the better the egg quality. And then after a certain point, when your AMH is super high, there is actually a decrease in egg quality, apparently. The opposite, when your AMH is getting very low, most likely there is an increase in the number of genetically abnormal eggs. And there are studies that we've reviewed that support that. But it's actually debatable because there are also studies that show that that's not the case. So we're not sure on the low AMH relationship to poor egg quality yet.
What do you think about immunomodulation?
So there's a whole field of reproductive endocrinology and infertility called reproductive immunology, with physicians and experts dedicated to dealing with the reproductive immune system. There are whole journals dedicated to this. So there is a journal of reproductive immunology. So there's no question that the immune system has a very critical role in implantation and maintenance of a pregnancy. Definitely nobody has worked out all the kinks into figuring out what needs to be where and at what level and all of that stuff. But there's no question that the immune system plays a role. I was at a really good ASRM sponsored panel discussion last year in Chicago, where they had a whole panel of experts discussing this exact topic. And the question was, what about all these immune therapies? And it was funny because even the people on the team that were supposed to be saying, yes, the immune testing and treatments are beneficial. You could tell none of them believed in it. They were just like fake supporting it because they had been told to. But everyone basically said, look, we acknowledge the fact that the immune system is important. We just don't know what to do with it because the data is not there yet. I'm going to say that in my view of things, there is data to support certain treatments. And if that's something you want to know about, contact us and we'll do a consult for you and go over it. But there are many studies on things like intralipids. There are many studies on things like IVIG. There are many studies on steroid use. There are multiple studies on other things like Plaquenil and tacrolimus and all sorts of agents that various people have tried, Humira and so on, to see if they can improve the outcomes of people who have chronically failed or had recurrent pregnancy loss. So whether or not each one or any of those medications or treatments is right for you is something that really requires the advice and careful consideration of a physician that is dedicated to you. Is definitely not something anyone should be looking online to find. You need to talk to a fertility specialist or a reproductive immunologist and make sure that they know what they're talking about and then go through with the treatment. So I do a fair bit of reproductive immunology because we have lots of patients that want that kind of advanced help. And so that's something we discuss with our patients, and I got to go through each treatment and I got to explain to them which one is appropriate for what condition, and we have to find out what condition they have. So oftentimes there's testing, and so it's individualized for each and every patient. Just saying I want to do intralipids because I have an immune problem, that's not the way it works at all. There are certain conditions where certain medications will work, and there are other conditions where other medications or the same medication won't work. So you need to talk to your physician to figure it out.
Hi, Dr. V&T.
Well, that was quite simple. keep it simple, the KISS principle.
How do you dose HGH for stems and for how long?
Okay, so that's a personal medical question, which I need to avoid. So I will say this. There are numerous studies, none of which agree on what dose or duration of human growth hormone to use. I've seen everything from very low doses in the studies all the way up to incredibly high doses in the studies. So that's a question you got to take up with your doctor to find out what their protocol is. The duration, the studies have looked at anything from with your stim, which is the shortest duration I've seen, to 6 weeks prior to stim, which is probably the longest duration I've seen. We tend to stick to a shorter duration in our own practice. And that's just what we do. I'm not advising you to do the same. It has to be individualized, but we stick to like 2 weeks before the stim and then through the stim. That's our protocol. We're using a reasonable dose, but again, it needs to be individualized for you, and you have to talk to your physician about anything related to specifics of dosing and so on. There are a million questions tonight, aren't there?
Oh yeah.
This is huge.
Hey, HSG report says left tube is normal caliber.
Okay.
And patent.
Okay.
However, ampullary Rugel folds appear somewhat irregular. What does this mean? Does it impact FET success? And how about natural conception? Thanks.
I've never heard of anyone reporting on the ampullary Rugel fold on an HSG, and I guess I would be questioning what kind of X-ray vision the radiologist had to be able to describe something like that, because I've never heard of that in my entire life, and I find it implausible that someone could actually detect that on a hysterosalpingogram. So I would be asking for clarification of what that means and how they figured that out, because I've never heard of someone reporting something in that level of detail. Rugel folds are the little ridges inside your tube. You can't see that on a hysterosalpingogram. It's literally not possible. So I have no idea how they figured that out. Sounds fascinating, but You definitely got me on that one. I have no clue.
Sounds familiar to my daughter's report card. The teacher said, the teacher gives my daughter a B
Okay.
in reading.
Okay.
And she reads like one book a week.
Your daughter.
Mm-hmm.
Okay.
Yeah. It's killer vocab.
She's a reading machine.
Oh, yeah.
All right.
So I asked him very briefly, so what is this based on? This B?
Yeah.
I'm fine with it if she sucks, but if she doesn't suck.
What did you give my daughter a
what do
B
you
for?
read? Well, she reads, but like, it's not just based on reading. And I said, but it says reading, B. He goes, but there's other things factored into it. So it reminded me of this, and it's like, what do you even do with this information?
I need to talk to your teacher, man.
That's what I thought.
Yeah, I'm an honors English major. I mean, reading means reading.
That's what I thought. I was told otherwise this weekend.
Wow, that one I cannot help you on.
No,
Yeah.
believe me.
Yeah.
Another question that you might be able to answer.
Yeah.
What is the approximate cost of IVF when paying out of pocket? Doesn't have to include meds.
We have numerous different packages, so it depends on which package you're looking for. IVF can be as cheap as $6,250 with us, and then we have packages that are more. We have double packages, we have triple packages, and then we have live baby guarantees. And then you move into donor, surrogate, donor and surrogate, guarantees with donor, guarantees with surrogate, guarantees with donor and surrogate. So the prices go up, but it starts at $6,250. That's our lowest price, and it goes up from there. If you're a resident of Ontario, you may be eligible for government funding. We did great with our funding this year, so I think we are mostly caught up. I don't want to say fully caught up, so don't be calling the office in a flood, but we are mostly caught up. So I think that we are going to do well in getting through our next year's list. So funding is always a possibility. I cannot assure anyone a funded cycle, and I have nothing to do with the list, so don't yell at me. I was smart enough to get out of the middle of that and hand it to my team. But the reality is that you are eligible for government funding, in which case you only have to pay for the storage of your embryos, your meds, and if you need genetic testing, that. What about funding for IUI? You just pay for the sperm wash, nothing else. So you just say, hey, I want it, and we get it done.
Got endo, but no pain. Only at early pregnancy and miscarriage surgery before next transfer. Risks of pregnancy with mild adeno is down. Regulating a must.
So does endometriosis and adenomyosis have an impact on fertility? Yes. That's very clearly demonstrated in so many studies I can't even count. The question is, do you have to have treatment? Okay, so again, I can't directly answer questions. The show is just about my opinions. I'm not going to give anybody direct medical advice. However, studies clearly show that endo and adeno have an impact on your fertility. It is less obvious whether or not endo and adeno have an impact on your miscarriage risk. And so again, I would talk to your doctor about that, because they have to analyze what your uterus looks like, how bad is your adeno, are there alternative options such as medical therapy, or is no therapy an option? How bad is your endo? How is it impacting things? Is it going to get better? Is it going to get worse? All of these things are things that you need to talk to your doctor about. I cannot answer those sorts of questions without knowing the specifics of your case. So you are all welcome to become patients, but you need to become patients for me to give you one-on-one medical advice moving forward.
Can you tell if a blast was split based on ICM inside?
No.
Any benefits of dairy, gluten, and red meat free for improving the likelihood of own egg pregnancy in POI or POF?
That's a great question. I am not aware of any studies to look at going dairy or gluten-free improving POI specific outcomes. So POI is premature ovarian insufficiency, or low ovarian reserve. I don't know of any studies that have shown that. That doesn't mean they don't exist, but maybe make a note of that, and I'll screenshot that one. I'll look it up. We'll see if we can find stuff for you. In terms of meat, red meat. So for those of you that don't know it already, and I know anything negative we put out there doesn't do that well. I put up the posts on how bad alcohol is for you, and no one watched those, which is funny. But anyways, so red meat increases your risks of colon cancer by 40% if you're eating it regularly. So should you all be avoiding red meat? Yes, desperately, please, I beg you, avoid red meat. It's terrible for you. So I would not recommend anybody have a lot of red meat. And that's not medical advice. That's the Canada Food Guide. I mean, that's the World Health Organization. I'm repeating stuff straight from them. So you should be minimizing your red meat intake. So pork, beef, lamb, all that stuff you should try and minimize. Fish, chicken hasn't been shown to have as much of a negative impact. Being a vegetarian is best. That's the healthiest approach to things. 9 o'clock.
9 o'clock.
Done?
That's a question of
I think
time.
I think we stay out of trouble and we just call it quits.
Yeah, that's wise.
Okay, so listen, we love you guys. We are going to be moving away from directly answering medical questions. Science, I'm all about, but for everything else, I cannot one-on-one answer your medical questions just because we don't want someone to follow advice without knowing your full history, and I think that's appropriate. So if you do need one-on-one help, visit info@drvictory.com. Don't visit. Email info@drvictory.com. Set up a consult. We will be happy to talk to you one-on-one. I usually spend an hour with my patients, go over all the details and explain everything to you. One last quick question. OB. For women with PCOS who don't produce any milk, any studies to back increasing it? There are agents that can be used. A lactation consultant can be very helpful for you. There are medications we use as well. Again, I cannot give you direct advice, but there are medications that we use. So seek out the help of your family doc, your midwife, your lactation consultant, or an OB. We all know the same medication. We use it all the time. So don't hesitate. Let us know. We can help you out. Okay, guys, have a wonderful evening. Next week, make sure you bring your donor and surrogate questions. And if you have anyone that you know of that is interested in being a donor or a surrogate, make sure they come, because we'll probably have at least one or two of each. And we'll be chatting with them and talking to them about their experience and what it was like and how they feel before and afterwards, and what it means to them to be part of that new family that they've helped create. How easy or hard it is to part with your eggs or part with the baby that you just gestated for 9 months. So join us for sure next time. If anybody has any topic questions that they want to know about, don't hesitate. From now on, we will be asking for the questions to be submitted in advance. So Tarek will put up a post and we'll get them all in, process them, and that way we can have some more graphics and stuff as well during the show. Have a great night. Take care.